Why are we here today? We are here today to learn and to share. Sharing is very important at these events, as you know. So we are here to learn and to share. Since with the advent of the Affordable Care Act, we begin a new day with new challenges. Challenges that will require us to continue to instruct, implement, and improve if we are to ensure better health care, affordability, and accessibility. We are here because we chose a career through which we can serve. That of itself makes everybody in this room a very unique individual and a very unique group. Because in today's world of Twitter, Facebook, Instagram, selfies, more and more, the focus has become serve yourself, care for yourself. There is no thought for the others, those that need our assistance, those that need our service. The tendency is to turn inward rather than outward. But we, all of us here, have chosen to turn outward. We look to better the quality of life for others. As a result, we are fortunate and glad that you join us today, that you join the campaign for better health care, and that today you once again affirm that we cannot stop the fight until everybody is in and nobody is out. Thank you very much. Okay, so our next speaker is Jim Duffett, the Executive Director of the Campaign for Better Health Care. Jim.
Good morning, and again, thank you all for taking time out of your busy post-holiday and pre-holiday schedule. I definitely, and thank you for bearing with the parking also outside. I want to take about 12 to 13 minutes to kind of lay out some observations and thoughts about the Campaign for Better Healthcare closing out our 24 years of healthcare justice advocacy, and as we embark on January 1st of next year, our 25-year anniversary fighting for healthcare justice with all of you. And how appropriate is it that as we begin our 25th anniversary next year, tens and millions of Americans will finally begin to get access to affordable health care. And I want to thank you and tens and thousands of Illinoisans around this state who've been locking arms with us in this fight over the last 24 years, and for some folks, much longer than that. We are all in this together, and we must stand strong and vigilant to make sure that, as Joan was saying, that everybody is in and nobody is out. And that as we move forward to implement and improve Obamacare, the focus must be on consumers. And we also know as we move into these new phases, it is a new day, and there are going to be new challenges that we need to work together on. I'd like to first, before I get into a couple points, for us to take a moment of silence in memory of friends and family and colleagues who fought not only for healthcare justice but social justice during their life and are no longer with us, and those who are struggling with difficult diseases, and definitely in the past week as we all have shared our experiences with Nelson Mandela's family. If we could just take a pause, please. Thank you very much. Again, I want to thank the campaign's board of directors, but I also want to definitely thank our staff. We have one of the best staffs around. They work long hours They juggle a lot. They do this work because their heart, their mind, and their soul is committed to a just and equal society for everybody. And we all love working with all of you, and that makes a big impact on all of us. So I want to thank you very, very much. I definitely want to thank Leslie and Abby, 2 interns. As people know, that one of our staff folks is struggling with a health condition, and so both these 2 interns of ours really stepped up to the plate and helped pull this together. So I definitely want to thank them. I want to touch on 2 points. First, as we move into our 25th anniversary, we're definitely going to be reflecting on the victories that we collaboratively have won together and the impact of those victories that have had on millions of Illinoisans throughout the state. And also, you know, how over the years we've helped to support the growth and the importance of institutions like community health centers, like public health districts, and the expansion of allied health professionals, and many other examples. In addition, when I reflect back on our 24 years, we've been able to develop stronger and everlasting relationships built on a lot of common ground issues, whether it's with the provider community, with organized labor, faith, disability, and now our very strong and growing small business initiative. That has made us all stronger, because we all know that we are in this together. Looking back over our history, whether it's been the passage of the Rural and Urban Health Initiative, ending Medicaid discrimination, banning door-to-door marketing of Medicaid managed care plans, the passage of a managed care Bill of Rights, the enactment of all kids, kid care, the Health Care Justice Act, opposing Medicaid cuts, leading the national fight back in 92, 93, 94, and in 09, 10, and 11 for national health care, or even going back to 91 to 93, leading the fight for single payer here, and in 2007 with many of you for Illinois covered, and most recently with many of you with the Medicaid expansion. Joining together, we all have made a difference, and we need to always remember that. Second, I know in 2010, you know, many of you helped CBHC develop a strategy campaign that we've embarked on as we begin to implement Obamacare. It's called the 3 I's. It's little fact sheets in your packet: inform, implement, and improve. And I really want folks to keep those 3 things in your mind as we move forward, and a lot more ongoing informing, implementing, and improving. Part 1, inform. The truth and the lies. And I know the Faith Caucus talked about this a little bit, about the issue of fear and how the opponents of Obamacare have kind of used the fear to move and scare people. No, Obamacare does not have death panels. No, computer chips are not going to be put into your arm. No, the IRS is not going to have access to all your records. No, Uncle Sam is not going to do a physical exam on young women before you can get medical treatment. And there's, you know, ads by the Koch brothers out there scaring young women not to sign up for Obamacare. And no, come January 1st, no matter if you have health insurance or you don't, the doctors and the nurses aren't going to sit down with you for 15 minutes and have you fill out a questionnaire about your sex life. All these things have made it through social media. All these things are going to continue. While the web problems are totally unacceptable and heads need to roll, what is more unacceptable is the 50 million Americans who have no health insurance and the lack of protections that many of us have. But what's great about that is that this is now going to be a footnote in the history of this country. It's no longer going to be a fact that the protections that are needed in terms of pre-existing conditions, higher caps, no elimination on caps and other things are no longer going to be an issue. While the website still has some problems, you know, it's interesting, I haven't heard Republicans talking about it very, very much lately. As we continue with our campaign to inform and to fight back, we got to continue to inform our friends, our colleagues, neighbors, our elected officials on reality. Obamacare, we know, started implementing back in September of 2010. Just over the past year, nearly 900,000 women in Illinois are receiving preventive services without a copayment. Nearly 5.4 million Illinoisans no longer have a lifetime limit on their health care coverage. 145,000 senior citizens just last year here in Illinois saved nearly $100 million in prescription drug coverage. 175,000 Illinois families received nearly $10 million in insurance rebates because of the medical loss ratio, that insurance companies have to spend 80 cents on every dollar on health care, and if they don't, you get a rebate. 125,000 young adults in Illinois are on their parents' health insurance. No more pre-existing conditions for individuals 19 and younger. And for all of us, because there's a few people here 19 and younger, but not too many of us, but all of us, 16 more days, 15 more days, that's going to be a footnote in history that we no longer can be discriminated because of a pre-existing condition. The cost curve is bending. CBO says that Obamacare is even going to cost tens of billions of less than what was projected. And the list goes on and on. You know, as we talked earlier, we must be very public about stating our stories. And again, as Joan had mentioned and earlier, really urge people before you leave, you know, be part of the story bank. Tell us your story. Tell us a neighbor story, a family member story, a colleague story, because we have to get that message out there. Part two, implement. You know, Obamacare is the floor. We have the ability to implement a state-based marketplace, or commonly referred to an exchange. We have the ability to build up upon it. And I'm going to talk a little bit more about the state-based marketplace shortly. And as you'll see in your packet, we believe that State Representative Gable and State Senator Kaler's bill is a solid bill in moving us forward for state-based marketplace. And shortly, we're going to hear from Brian Gorman about Illinois' education and enrollment efforts. And I don't want to take away from that as I get into some of the other issues of implementing and improving. But we know the education and the enrollment has to be a top priority, not just this year till March 31st, next year and the years after that. And as we were talking a little bit in the Faith Caucus earlier this morning, it's not just about health care. You know, there are roles that government can play in partnership with the private sector, and there may be some roles that government should not play. This is so important, not just for health care, that enrollment, but for many other issues that we all care dear about as the role that government can play. We have to make sure that enrollment succeeds. And there's going to be many other positive elements of Obamacare that when we get to the state speaker later this afternoon, the people on that state panel will be talking about. But we're going to need your help again to continue with our mission to make sure that the Illinois General Assembly moves forward and passes a state-based marketplace. And even during that state panel, we're going to talk and have greater discussion about why we believe and why these organizations believe it's so important. Part three of the 3 I's is improve. You know, our history tells us that, you know, social justice success doesn't happen overnight. And that when we do win, we should never feel that that victory was not as sweet as it could have been. Boy, if we just could have got the public option. Boy, if we just did that. We need to step back and really see all the different victories, all the different successes that are in our Obamacare. And we also know that this struggle has to continue. It doesn't end. And we should never downplay this victory of over 100 years of fighting for. We won, and our country won. And we need to be proud of that, and we need to keep on pushing hard on that. You know, we look at our history on Social Security. You know, when Social Security passed back in the 1930s, it only covers 1/10 of who's covered today. There have been at least a dozen pieces of legislation that we have had to fight for. Our fathers or grandfathers or grandmothers or mothers have fought for over the years to get Social Security where it's at. And we always have to keep on protecting Social Security because there's always going to be those folks out there who want to privatize it and rip the system apart. Same thing with Medicare. When Medicare passed, there have been at least 6, 7 different pieces of legislation on Medicare. We know that's going to happen with Obamacare. Our fight, again, in Springfield next year is on a state-based marketplace. You know, last year, we ended up passing the bill out of the Senate, 37 votes, all Democrats. The Republicans were in a tizzy. They weren't sure exactly what direction that they were going to do. If they voted for this, then they embraced Obamacare, which they would have probably a Tea Party person running against them. If not, most of them are maybe Tea Party people already. If they didn't vote for this, which they didn't, they basically were embracing, you know, the big bad federal bureaucrats in Washington, D.C. in controlling. In the House of Representatives, within 36 hours, we ended up getting close to 40 supporters on this bill. But unfortunately, the Speaker of the House pulled the plug on it. Why is a state-based marketplace important? Again, I want to stress it provides a floor. We have the ability to build upon it, and I'll talk about a few of those things. First, you know, the federal government and Department of Health and Human Services, they didn't want states to live off a federal marketplace. They are wanting to move states to go towards a state-based marketplace. We're in a unique situation temporarily with the state-federal partnership, but they don't want to be managing 35 states right now. Number 2, politics. And this is just my cloudy crystal ball, is that I really don't see substantial legislation happening in the United States Congress for at least another 10 years. Whether the Democrats win control of Congress next year, I think many of those Democrats are still going to be very scared to be supportive of Obamacare. And I think really, frankly, until the Democrats end up getting 30 to 40 seat majority in Congress, could be before some major pieces of legislation, they deal with some of the issues that we know that are out there that we'll talk later about that will need to be fixed. Third, a lot of positive change can be made at the state level. We can improve and control the enrollment process that I know Brian may touch on in his talk. By having a state-based marketplace, we're going to be able to have more decision-making here at the state level. What tweaks do we need to do? Some of those tweaks we can do, but if it's a federal-based marketplace, we may need congressional action. And again, I would say that it's going to be a good 10 years before we see substantial action at the federal level. Plan improvement. You know, we have the ability to look at these plans that the folks have signed on and be able to tinker with them. Is there enough of focus on public health? Is there enough of focus on preventive services there? We have the ability to go and change those plans to really deal at a lot of those issues that many of us have fought for. We also have the ability to deal with health disparities, racial disparities. You know, there's a lot of great work that many of our legislators have worked on, but this is another realm we have. We can develop these plans to make sure that they're all cultural competent, happens across the board, and to deal with a lot of the disparities that are out there. We also have the ability to start to put some checks and balances on costs and quality. We can improve quality. We can definitely improve costs. You know, we're hearing some issues about adequacy of network, that some of the plans don't necessarily are kind of excluding some of the providers. Well, why is that? And what can be done? Well, very little can be done other than if we had a state-based marketplace that we could really enforce to make sure that there is a wider choice of providers that people can go to. Eligibility, we're going to hear about eligibility later too. What can we do for the 300,000 Illinoisans who are not allowed to get into the ACA? It's not going to happen at the federal level. It can happen at the state level. And there's also a lot of unknown issues that we don't know what's going to come down the pike. But without a state-based marketplace, we're not going to be able to do it. So what needs to happen? Well, some form of legislation needs to happen by May 31st. And it has to deal with the makeup of the board and who's going to pay for it. And if we don't pass anything by the end of May, the state is going to be forced to give back $160 million, potentially. And then we do have the ability to pull down $150 million. I've even heard $200 million from the federal government to set up our own state marketplace. If we don't pass it this year, does anybody think we have $300 million in the kitty next year or the year after that? Of course not. It's not gonna happen. There's some people who want to take Representative Gable's bill and Senator Kaler's bill and turn it into a one-page bill. There's some key components in that bill. It's not a perfect bill, but there's some very key components in there. One is the makeup of the board. I'm not going to go into it, but you can read. We believe that board needs to look like us in this room, quite frankly. It needs to have special interest groups on there that have historically had a problem in getting access to health care. It needs to be very broad-based. We also need to know, how's it going to be paid for? Well, you know, the insurance industry, they're sitting on $33 billion. That's a B, not an M. $1 billion just here in Illinois in excess revenue that they have in reserves. And plus 1.2 million new Illinoisans are going to get into the system. And if I'm an insurer, I'm not going to go into a system that I know I'm going to lose money. They're going to make money. So we feel that the insurance industry, and this is a spit in the bucket for them, you know, it could be $56 to $89 million. We believe the price tag should be more like $125 to $150 million. So there's ongoing money for public education out there, folks going, getting more people enrolled year after year after year, and also media work. We don't believe that there should be a surtax on the uninsured who are getting into the exchange. We don't believe there should be a surtax on the providers. We don't believe there should be a surtax on small businesses. You know, the providers, I mean, the insurers are doing well. They're doing well in this economic climate, and they'll continue to do well. So basically, we're in this together. We understand that it's a new day and that there's new challenges. We will hear and learn more today about the new challenges that can produce new opportunities. I want to thank you all again for everything that you have done individually, organizationally. CBHC looks forward to working with you next year, and I do believe that the rest of the morning will be stimulating and we'll begin developing a broader path on what we need to do. So thank you very much, and happy holidays. And Joan, I'll have you introduce Brian. Thank you.
Thank you, Jim. It's my pleasure to introduce our second speaker, Brian Gorman. Brian is currently the Director of Outreach and Consumer Education with the Illinois Health Insurance Marketplace. Previously, Mr. Gorman was the former campaign organizer of President Barack Obama. He worked with the Democratic National Committee from 2009 until 2011. During that time, he organized on behalf of the Affordable Care Act, as well as the repeal of Don't Ask, Don't Tell. Mr. Gorman also recently acted as the senior campaign advisor in the Illinois Senate Victory Fund. Please give a very warm welcome to Mr. Brian Gorman.
Thank you. Good morning. Joan, thanks very much. I'd like to thank Jim and the Board of Directors for Campaign for Better Healthcare for inviting me here today. And I think it's also somewhat challenging at times to follow up. Jim, he usually gives a lot of energy, and it's more of a campaign speech, and it's a difficult act to follow, but I will do my best. I am the Director of Outreach and Consumer Education for Get Covered Illinois. Get Covered Illinois is the official online marketplace, as those of you know, for those that want to shop for and compare both plans on the Medicaid side as well as the marketplace side. Get Covered Illinois is the place where you need to go. As mentioned in Jim's comments, the state of Illinois is in a partnership relationship with the federal government. So when a consumer ends up on the marketplace or the exchange, they will not be shopping for those plans on our website. They are transferred to healthcare.gov and the federally facilitated marketplace. I know that everybody in this room is well aware of some of the challenges that have been placed upon the state and those consumers who are looking to shop for those plans, and I'll touch on those as well and to talk a little bit about how we're solving those. But I want to talk this morning about kind of how we got to where we are today, some of the benchmarks and key successes we've seen as a marketplace, and then give everybody here a look forward to what we can expect, not just for the next 3.5 months of open enrollment, but what to expect for the next year, year and a half, and what our hopes and ambitions are for a marketplace. So I started in January of last year, and I was brought on board not because I have tremendous experience in healthcare policy or I've got a long and storied history in government. I was brought on board to create this grassroots campaign. Governor Quinn understood that for where we needed to be as an organization and to provide access and affordable health care, we needed people to understand and know what the Affordable Care Act means for them. We need to educate the public and ultimately build something sustainable so people can actually enroll when the time is right. Asterisk, when the website is fully functioning as well. So we kind of looked at, well, what does this look like? What is our vision for the marketplace? What is our vision for Get Covered Illinois? And the first thing we wanted to do was we wanted to create a culture of coverage throughout the state. We knew that we didn't want to have individual conversations with a very confused consumer base about whether that they were marketplace eligible or Medicaid eligible or marketplace with subsidies. We wanted to connect with them and talk about what coverage means. How if you and your family and your small business are covered, you'll never have to worry about going bankrupt because you or your family got sick again. We wanted to start having conversations about what coverage means for wellness, for you and your family. It wasn't about kind of whether they're Medicaid or Marketplace. We wanted to make sure that people knew what coverage was. And that really is guiding a lot of our strategic decisions, but also our communication strategies in the short term and in the long term. And the second thing is we wanted to make sure that we were empowering community-based organizations throughout the state to do the heavy lifting, the education, the outreach, the enrollment. The governor's office, or even the people in this room, while well-intentioned and bright and energetic, may not be the best ambassadors to connect with the people in the communities who really have no idea of what the Affordable Care Act was. So it was important for us to give community-based organizations throughout the state the training, the tools, the resources they need so they could be the ones that went out there and introduced what the ACA is, what the culture of coverage could mean for them and their families. So with nearly $27 million in federal Navigator grants, we granted 44 lead organizations in the state and have developed 240 plus sub-granted organizations across the state to hire and train and certify federal navigators. So as of today, the state of Illinois has 1,500 certified navigators who are working throughout the community. They are located in areas which are directly proportionate to where the uninsured reside, trying to meet all the communities of need and to make sure that folks have the information and the access that they need in order to make a decision about what it is to enroll. So we're really excited about where we are in terms of that infrastructure and capacity building. I know that a lot of the narrative across the country and in politics is about this either rate issues or whether or not you'd rather to keep your plan, whether the website is functioning and working. None of those things matter unless the state and states have the capacity to connect with those people that need it. We know that 60% of the people that we're counting on to enroll between today and March 31st will need some form of assistance in filling out that enrollment. And so without that capacity, which takes months to train and build, we will not be successful. So I can say with confidence and with pride, the state of Illinois is where we need to be in terms of developing that capacity and to provide that assistance for consumers. Secondly, obviously, awareness is a huge barrier for everyone. Everybody is aware of the statistics, both not just in young people, but across all levels of uninsured. Nearly 69% in Illinois at the start of October 1 had little or no information on what the Affordable Care Act is. Think about that. On October 1 of this year, 69% of the uninsured in Illinois had little or no idea what the Affordable Care Act meant for them. So we knew that the barriers were enormously challenging. Secondly, the atmospherics for the first 2 months of the campaign, October through November, were toxic, to put it mildly. So all of these barriers, you add up the lack of information, the very challenging atmospherics and the communication level, and the general lack of understanding from the consumers between the cultural and historical barriers, you know the size and scope of the challenges we face. So it's not, this is the worst. We are now at that floor. And so what have we seen? So since December 1st, when we have a mostly functioning website, I can report that, like the White House had promised, healthcare.gov does in fact work for a vast majority of Americans. And every day I get dozens and dozens of reports from navigators in the field who are actually doing the work, who are enrolling people both through Medicaid and our ABE system, but also in marketplace plans. I'm hearing the stories of people who literally were in tears. And I'm not trying to create an overly dramatic situation, but these are true stories of people who have been in tears as they finally have been able to get enrolled for the first time in their lives. They finally have access to quality, affordable care. And when we talk about the number of applications, both through county care and through the Medicaid and expanded Medicaid, what we've seen just in these last couple months, we know empirically and factually those people who are enrolling more likely to live in 2014 than they were in 2013. So we are slowly moving forward, but we also recognize that there is a lot more work to do. So from a campaign communications standpoint, we were very reluctant to launch a long, far-reaching paid media campaign to direct consumers to take action into some place where they really couldn't. We didn't want to create more negative goodwill. So just Friday, we actually launched a $1 million paid statewide, both Spanish and English media buy just for the next 11 days. The importance of getting everybody covered as we can before December 23rd, so they're eligible for January 1, was something the state is heavily invested in. We have nearly 300 enrollment events throughout the state with all of our community partners just in the next, between today and December 23rd. The idea that consumers will go to getcoveredillinois.gov, find an event near them, they won't have to travel very far, and they'll go to a trusted and known community-based organization in their community. And so this advertising campaign will continue to grow. We have the resources to connect people, to drive them to Get Covered Illinois, but also because of the work of our community partners across the state, we have the infrastructure on the ground to help facilitate the enrollment when the consumer is ready to make a choice. So I know the numbers that we've seen on the private marketplace side are disappointing, but we're also seeing essentially a hockey stick. If you kind of look at a graph over the last 3 weeks, it is the trajectory of the enrollment is on its way up, and I don't see it plateauing anytime soon. So as our paid campaign and our earned media campaign continues and are driving folks to our navigators who are serving those communities, we will be in a very, very strong position. So I know that there were some questions that were submitted, and I think that's probably a good place to leave off.
Okay. It's on? Okay. If there are questions from the audience, we'll entertain those as well. So I would ask, does anybody in the audience have a question for Brian at this time? Okay. If not, there were some that were submitted through the website. And one of those is, what outreach activities have you found to be the most effective thus far?
So, the honest answer is the outreach activity which is designed and created by and serves the community at which they want to serve. My office could create dozens of activities across the state, but it doesn't have the local flair. It doesn't necessarily connect with the community-based organization the same way that empowering the community-based organizations that we have. I kind of think back to the launch of this campaign, and there was a Pilsen Little Village. One of our granted partners had launched a Day of the Dead. They wanted to bury and to wish goodbye to the notion of pre-existing conditions. And dozens of community members came out to this event. And it was culturally, it was wonderful. They had food, and they had multi-language navigators there. The number of enrollments was dramatic. That's something that I simply don't have the creativity to create. And so that's an example of how our office providing the resources and giving a tremendous latitude to organizations, not just here in the city, but across the state, to say, okay, what works for you? You know your community member best. That's why we've hired you to actually do the work. Make sure that you're touching on these points, so we're making sure that they have kind of the messaging and the skills to do the outreach and the education and enrollment, but really trusting those organizations to get out there, to educate, and to build that facilitator. And I can promise, I'm proud to say that as of today, since we launched this campaign over the course of the summer, and we've been slowly bringing our granted partners on, we've had more than 4,000 outreach and education events throughout the state. And that number is only going to grow. So despite what we've not seen on television in terms of advertisement, the word of mouth ability to connect with individuals has really been on the backs of the navigators and organizations who've been doing all that work.
And that's a good segue into one of the other questions is, can you explain the difference between a navigator and an assister? So
there were three separate programs where the ACA provided either through statute or rule to assist individuals in enrollment. One was the Federal Navigator Program, which was federally granted and federally selected, and the state's burden was to train. The state also got that $27 million, which I mentioned earlier, for a state-specific in-person counselor program, which the state selected, the state had trained, and they're serving the same exact function, providing outreach, education, and ultimately enrollment when the time is right. The third assister element would be the certified application counselor, which is a non-granted position, but also allows someone to be certified and to be trained to enroll someone. So organizations who want to provide the service but don't have grant dollars, or the provider communities, hospitals, clinics, that's a tool. So right now, just from the consumer standpoint, we are trying to bring all of them together into a blanket navigator program. I think it's the term that most folks, both locally and nationally, are aware of. We don't want the consumer to wonder whether we're standing before a CAC or an IPC or a navigator. We just want the person to know that, okay, this person is certified to help. They're part of my community. They can help me. I don't really care what they're called. But as a branded effort, the state is going to be referring to all of our assisters as navigators going forward.
And I think it'd be good to ask the question, how does one direct somebody to, where do you find the organizations to direct people to do the enrollments? Because there are 2 or 3 questions here that are very similar. And the commentary before the questions of each of these individuals was, I've been approached by a broker. Mm-hmm. I've been approached by somebody in my neighborhood who says they can enroll me. I gave them my social security number, all of my information, and have not heard anything from them. Do you think I should have done that? We all, I think, would say no. But I think a good question is, where do we direct people to in order to find the organizations that are partnering with your department in order to enroll individuals?
Right. So that is a very good question. I would also like to start by cautioning anybody to providing their social security number over the phone or at the door. Get Covered Illinois is not making, and our partners are not making phone solicitations for enrollment over the phone. We are not going door to door and soliciting you to enroll in anything. So that's one of the things we're trying to communicate both in the communities, and obviously we need to do a better job of letting everyone know that no one should be enrolling you at the door. Secondly, all the help, all the assistance that you need can be found on getcoveredillinois.gov. That includes federal navigators, state IPCs, and certified application counselors can all be found on our website. And essentially, it's finding help. You can enter your zip code, your neighborhood. It searches by both 2 miles, 5 miles, 10 miles, and 20 miles. And it has numbers and contacts. So if a consumer has questions and they're looking for assistance, they can find certified help in their area. They can make an appointment. They can find out if there's a health fair or an enrollment event that are taking place in their communities. But that is and will be the best place where consumers can find help that they know have been certified and trained and are trustworthy. Another element that you brought up is that agents and brokers have a role to play in help facilitating enrollment. And obviously we had hoped for a much more robust SHOP program, which is the small business enrollment program. We envisioned agents and brokers to continue and to expand upon that. But agents and brokers can also be certified through the federal government to sell plans on the marketplace. They are not held by the same rules as navigators and IPCs are. They can actually steer people towards a particular plan. But we're confident that if folks are purchasing plans on the marketplace, they're getting quality plans which meet all the 10 essential health benefits. It's just another avenue. Agents, brokers, application counselors, navigators, friends in the community, libraries. These are all on-ramps to helping people who need coverage get coverage. And that is the most important thing as far as we're concerned.
I'm going to combine two of the questions into one. An individual had gone out and applied for health insurance and found that while the premium was affordable, and he or she was eligible for help, so the premium was affordable, the deductible came down a little bit, but there is a question about high deductibles, even though the premium may be affordable. Can I afford the deductible, and can I afford the out-of-pocket, and can I afford then the insurance, which in some cases is 20% of the cost? The insurance company is paying only 80% of the cost. And is there anything that the local groups, organizations can do to work with the state, with your department in particular, to make sure that whatever happens in Illinois, that we have insurance policies that truly are affordable?
Okay, so a couple of things. Obviously, the role of navigators is not just to help them fill out an application, but they've been trained to help facilitate enrollment. And part of that facilitation is to walk them through what the plans are, what the prices mean for them and the consumer. So the first thing that happens is that there's a subsidy determination is made. So the plan may cost X dollars, but because of your subsidy, you can see that this will now cost you X minus whatever your subsidy is. So you really have a good sense of not only what those premium reductions would be, but also those cost-sharing reductions as well. Because there are a number of plans on the marketplace, there may be a number of different levels that meet certain needs. And obviously, if you go to a bronze plan, what you're going to have is a lot lower premium each month, but you are assuming a larger risk in terms of your out-of-pocket costs. Now, these are all kind of actuarially consistent. The burden is on those of us who are trying to help educate the consumers and make sure that they can actually afford the cost and the deductible if, in fact, they do get sick. I also want to make sure that when we're communicating the selection of plans, it's important that regardless of whether you're getting a gold, silver, or bronze plan, that preventive care is included in those plans as well. So it is complicated, but it's also individual. But I'm confident, given the 2-day trainings that our navigators have, the 20 hours of the federal online training, that they are equipped to have those important conversations with the consumer. And this is a fundamental sea change. I mean, that this is something a lot of individuals who have not had access to health care are now going to have to budget for their premium payments and their out-of-pocket costs the same way that they would be budgeting for a cell phone bill, a cable bill, or their light bill. And we recognize that this is not something that is easy. These are an expansion of the private marketplace with federal subsidies to help with premiums and cost sharing. So, one of the things I'd like to point out is that, the grants that the state has issued are year-long grants. They start in July 1st, 2013, and they continue all the way through July 2014. And so if you just look at what that calendar means, at a minimum, only 50% of that grant period can be used for the purposes of enrollment. That other 6 months needs to be a period of education, not just on what the marketplace is, but some of the consumer and health behaviors that a lot of the folks who are now getting involved for the first time are going to be experiencing. So when we think about, obviously a lot of the focus right now is on enrollment and making sure that as many people are covered as possible. We're already planning and thinking about and partnering with a lot of people in this room on what that post-enrollment education period looks like. Because if people do not make their premium payments, they are not going to be covered. And if somehow we work so hard to get someone to finally get into what this culture of coverage means, and they get dropped off, that trust barrier that we work so hard to connect with will be lost. So, this does not end in March 31st when the enrollment period ends. This continues. And that third eye that Jim talked about, improvement, is not just on the policy itself, but improving on how we communicate what a proper healthcare delivery system means and how people interact with healthcare is something that will go on beyond just this year, but will go on into the future.
And this will be the last question. Is your department receiving feedback from those individuals, and many of them in the audience today, who are doing the enrollments as to the difficulties, the positive things that have occurred, what needs to improve, so that, as you said, post-enrollment, we can make sure that the individuals who enrolled actually stay enrolled?
Yes, so I get feedback every day, and it's important that not just the way we've developed our organization, that information flows both to the granted partners in the community, but on a daily basis, we are getting information back up. Where are the successes? What are those personal stories that can really shape and define what this is all about? But mostly, what are the policy changes that we need to improve? And I know Jim talked a little bit about the importance of a state-based marketplace. One of the most frustrating elements of this entire process is the fact that the state of Illinois, through our Get Covered Illinois teams and Healthcare and Family Services and all of our government partners, have met all of our deadlines and all of our obligations as far as that partnership relationship. The vast majority of our issues are related to the fact that we do not control healthcare.gov. So we're waiting a lot of times for information from our federal partners to come back. And that's not, I'm not assigning any blame to them. It's just the reality is that they were never designed to stand up as many marketplaces as they were. So making sure that the Medicaid side and the marketplace side have a smooth transfer of files, something that's been in the news that we're working diligently on. The idea that because we are in a partnership relationship, the fees that carriers actually face in Illinois are larger than they would be if we were our own state-based marketplace. And that is not, we all know that those fees are not absorbed completely by the insurance carriers. Those are passed on to the Illinois consumers as well. So if I may advocate just for a moment on some of the things that may improve the consumer experience and health outcomes by a state-based marketplace, I will take that moment. But the reality is that this is the arrangement that we as a state agreed to, at least for this first year. And we're proud of the work we've done both on our infrastructure build, on our state-based call center, where we're seeing calls increase every single day, and on getcoveredillinois.gov. I mean, from October 1 right on through to today, we've been up, we've been live, we have not been down. Our screening tool, which allows people to be either moved directly towards the marketplace or to ABE, which is the state Medicaid eligibility determination, has performed well. So there's a lot to be proud of as a state. And before I wrap up, and I just want to kind of acknowledge the work of everybody that's been done in this room, and just it's kind of humbling to read through that this is the campaign and a lot of the advocates in this room have been doing this for 25 years. And I'm not old, but I haven't been in the professional realm for 25 years. So I appreciate that all of the work that has been done to get us to this point today. And I'm excited about what we've accomplished. I'm thrilled on what's ahead of us, and I'm eager to get to work to improving the system both in state and across the country to improve health for people all across the state of Illinois. So thank you very much. I appreciate everybody's time and enjoy the rest of the day and look forward to working with you over the next few months. Thank you.
Our next panel is a national perspective. And what we wanted to do here was to kind of have a perspective of what do we need to be doing in 2014, again, outside of enrollment and education, but what's happening in our nation's capital and national policies overall. What do we need to do both offensively and defensively? What are the known and possibly unknown issues that we need to be aware of and begin planning for them and developing and implementing advocacy agenda over the next 5 years? And how do you see Congress dealing with the ACA, needed or not needed changes next year and over the next 5 years? Our first speaker is Ron Pollack. And Ron is a founding executive director of Families USA. Over the last 30 years, Families USA has earned a reputation as a prominent voice for healthcare consumers. Ron has been featured many times on TV and radio programs on healthcare across the board, but definitely in the battle and passing the ACA. And whether it's on NPR, All Things Considered, Good Morning America, Modern Healthcare. Modern Healthcare named Ron as one of the most top 100 most powerful people in healthcare, and the Hill magazine on Capitol Hill named him as one of the top 9 not-for-profit lobbyists. I also want to say that on a personal note, a friendship with Ron going back to 1988. As many people know, it was, before it was Families USA, it was Villar's Foundation, and I remember meeting Ron in 1988 and 1989, and they were the first funding source for the campaign, $35,000 grant to get us started, and I have leaned on Ron a lot over my 25 years almost at the campaign for guidance and help, and you've definitely been an impact on me in dedicating my life for healthcare justice. And with that, Ron, I'll let you.
Good morning. I'm delighted to be here. I'm delighted to be with Jim and Joan, It's always an inspiration to have any connection with the Campaign for Better Health Care. When Jim said we first met in 1988, it was a pretty early period for me. I was just out of my teens, so it was quite a learning experience. And I have to say, Jim, I thank you for rejoining me with my father, Harold, who will be speaking momentarily. Jim had asked me to talk a little bit about where are we going over the next 5 years, and I'm happy to do that. But I first want to talk a little bit about the Affordable Care Act, because obviously it needs very effective implementation. I must say I have some fear about talking about the Affordable Care Act because I do it a lot, and I'm afraid what is there that I can say that's not redundant? So if you don't mind, I'll tell you the story that I most worry about happening to me again. A few months ago, I was giving a talk about the Affordable Care Act, and I was looking around the room, as I am now, to see whether anyone was paying attention to me. And fortunately, on that particular occasion, people were seated in a kind of a classroom-style arrangement. I noticed there was a woman in the fourth row taking copious notes of everything I was saying, and I felt, this is great. I'm actually reaching somebody, and I could feel the adrenaline coursing through my body. And I thought, actually, I gave a pretty good talk. However, at the end of the talk, a few people came up, and this woman was the very, very first one. She had this warm, wonderful smile on her face, and she said, Mr. Pollack, I want to thank you. You were absolutely superfluous. So what do you say? I thanked her. But she went on and said, you know, Mr. Pollack, I want to know, do you intend to do some writing on this subject? Well, I thought a moment, and in the spirit of her previous comment, I said, yes, I intend to do some writing on this subject, and I hope to have it published posthumously. And she looked at me with this warm, wonderful grin and said, you know, that's just wonderful, Mr. Pollack, because it just couldn't happen too soon. So I hope I'm not superfluous, and trust me when I say I'm delighted to be here in some guise other than posthumously. So let me just say a few words about the Affordable Care Act before I focus on what Jim really asked me to do, my assignment for this morning. I want to talk about why is it what we're doing with respect to the Affordable Care Act, why is it so important? And you have to start from the fact that in our nation, according to the last numbers we've seen from the Census Bureau, there are 48 million people in the United States who are uninsured. This is extraordinary. In the richest country in the history of the world, we have 48 million people uninsured, more than 1 out of every 7 Americans. And perhaps it's hard for any of us in this room to grasp what 48 million really means. So the only way I can think of trying to relate to this is 48 million is more than the combined population of 24 states plus the District of Columbia. Now, obviously, I'm talking about the least populous states. But imagine, if you will, we have more people uninsured in this country than the combined population of almost half the states in our country. And to make matters worse, the 48 million figure that we focus on, that the Census Bureau tells us about, the analysts tell us, is really, that's a point-in-time estimate. It's how many people essentially were uninsured at the time the survey was undertaken. And yet we know there are lots of people who are uninsured at some point of the year and then get coverage another part of the year. And if you take a look at the number of people in our nation who are afflicted with not having health coverage at some point over the course of a year, it's much higher than that. Before the Affordable Care Act, we at Families USA kept on doing reports based on other Census Bureau data. And for the last 2-year period, 24 months, the number of people who are uninsured at some point in that 2-year period was 87 million people. Now, if you take that number and think about that in comparison to the non-elderly population, the elderly have Medicare, it's almost 1 out of 3 people under 65 years of age. That's extraordinary. And why has that happened? Well, the predominant way that we in our nation provide health coverage, especially as a result of post-World War II, is we provide health coverage mainly through employers. It's still the predominant way that we provide coverage today. But there have been very significant changes that have occurred with respect to employer-sponsored health insurance over the past decade. In the year 2000, the average cost for family coverage provided through an employer was $6,500. Today, it is approximately $16,000. And so just in the period, in the 1 decade from 2000 to 2010, we've seen a significant reduction in the portion of the American population that gains its coverage through employers. In the year 2000, 65% received coverage through employer-sponsored insurance. 10 years later, it was 55%. So we've seen a significant reduction in the predominant way that people get health coverage. And then to make matters worse, for those people who fall through the cracks, we're supposed to have a robust safety net. But that safety net, if you really examine it, for so many portions of the public, is much more whole than it is webbing. We treat people not just differently from one state to the other, but we treat people very differently based on family status. So for children, due to the confluence of Medicaid and the Children's Health Insurance Program in every state across the country, eligibility standard is at least 200% of the federal poverty level. And in some states it's higher. New York, it goes up to 400%. New Jersey, 350%. But we treat parents very differently, and we treat other adults totally differently. The median income of eligibility around the country in the 50 states for parents is not 200% of poverty. It's 63% of poverty. It's less than a third of the eligibility standard for children. And that means in Texas, for example, for a 3-person family, you're ineligible for Medicaid if your annual income exceeds $3,737. It means in Alabama, the eligibility standard is $3,221. And this is not just the South. It's not just the Southeast and the Southwest. In Pennsylvania, eligibility ends at $7,400. And so throughout the country, we've had children eligible for coverage due to the confluence of Medicaid and CHIP, but we don't have their parents eligible. And we all know that if the parents don't get coverage, often the kids don't get coverage as well, because it's so much better to get coverage and enrollment as a family as a whole. But as bad as that is, for non-parental adults, still in 43 states as of this moment, it makes no difference what your income is, you're ineligible for Medicaid. You literally, not rhetorically, you literally can be penniless and you're ineligible for Medicaid if you're a single or childless couple. So that was the backdrop to the passage of the Affordable Care Act. We now need to provide really a floor under which no one can fall through, and the Affordable Care Act does that. The Affordable Care Act actually does something remarkable. So it enables us to expand the Medicaid program, and half the states now have accepted doing this. The other half have not yet done so. For a family of 4, income eligibility goes up to 138% of poverty, $32,500 for a family of 4. And then, with respect to the marketplace, we're doing something we've never done before. We're providing subsidies for people that will make premiums much more affordable. So for a family of 4, the subsidies go up to $94,200 in annual income. It reaches significantly into the middle class, and certainly for moderate income families. For an individual living alone, eligibility up to $46,000. This is extraordinarily important. And of course, as Jim mentioned in the beginning, it does a whole lot more in terms of changing insurance market practices. No more pre-existing condition exclusion. No more discrimination based on health status. No more charging women higher premiums because of... No more terminating coverage when somebody gets sick. No more annual or lifetime limits in coverage. These are significant reforms, and we should herald those reforms. So our job now is, as you're hearing from all the speakers so far, is to make sure that everybody who potentially can benefit from this actually knows about it and gets enrolled. And the key thing to understand, and this is why the task all of you are undertaking is so important, we still have an enormous percentage of people in our nation, and I'm sure in Illinois, who are unaware that they can get help by the Affordable Care Act. And our job is to do that public education so that people learn not just about the debate that's taking place in Washington and the pros and the cons and the vociferous debate that's taking place, but they should know how this is going to affect their lives and their families' lives. Now, I don't want to suggest that the Affordable Care Act is nirvana. I am thrilled with the enactment of the Affordable Care Act. It is the most significant piece of legislation, at least since 1965, when Medicaid and Medicare was enacted. But it's not perfect. And, I remember shortly before the vote took place in the House of Representatives, I was going over to then Speaker Pelosi's office, and as I was going to her office, coming out of her office, was a wonderful congressman, very progressive, the co-chair of the Progressive Caucus in the House of Representatives, a congressman from Arizona, Raul Grijalva, and I had read in the paper numerous times how Raul had been very critical of the Affordable Care Act. And as we were passing each other, I said, Raul, do we have your vote next week? And he gave me this long list of all the things that were shortcomings in the Affordable Care Act. And I said, Raul, I agree with every single thing you said. Do we have your vote next week? And he started again, and I said, wait a minute. There's a little takeoff from what you said earlier, Jim. I said, Raul, if I asked you as a progressive, what are of the half-dozen most important pieces of legislation in the history of our country, could I assume that the Social Security Act of 1935 would be on that list of the top half-dozen pieces of legislation that you say? And he said, absolutely. I said, what do you remember of the Social Security Act of 1935? And he looked at me and said, I don't really know the history. I said, Raul, what if I told you that the Social Security Act of 1935, as enacted, failed to cover over half the women in the workforce from its protections? And what if I told you that the Social Security Act of 1935 failed to cover over 2/3 of the people of color in the workforce, would you feel the same way that you just said that you savored as one of the top half dozen pieces of legislation? And he looked at me and he was very puzzled. And I said, don't answer that question. You were right in saying that that was one of the top pieces of legislation in the history of the country. We fixed those things. And we created a platform upon which we can build. And that's what we need to do with the Affordable Care Act. If we don't have that platform, go ahead, you can clap. So there are things that we need to do, and I'm not going to go through the litany of them, just pick out a few. We need to improve the subsidies that are being provided. They're provided on a sliding scale, and that's good, and the sliding scale means that young adults have a real incentive to get coverage, because by a sliding scale, we provide the greatest help for those people who need the greatest help. And young adults tend to be people who are either continuing their education, or they don't have a job yet, or they're in entry-level positions, so they have lesser income, and therefore they're going to receive greater subsidies. That's helpful. But that does not mean that the subsidy system is adequate for everybody, and we need to improve it. We have to make changes. The law allows states to add a 50% surcharge to those people who smoke. And guess what that's going to mean in terms of those people who smoke? Now, I don't want to encourage smoking. Neither does the American Cancer Society. But we think this is a very harmful provision, and it's going to preclude a lot of people from getting coverage. There's a provision in the statute that is going to come back to bite us a bit, and that is those people who've got varying incomes, they will sign up for the subsidies, and then at the end of the year, they may have gotten a bonus on the job, or they may have gotten a raise, and the IRS is going to look at the total income at the end of the year and say, you got too great a subsidy, and you have to pay it back. We have to fix those things. So there are a lot of things that we're going to have to do to fix. So that is part of the agenda. But the most important thing that all of us need to do is to make sure that everybody who's eligible for coverage and who can get help actually receives it. Now, we are right now in a period where there is enormous contentiousness about the Affordable Care Act. But I want you to take a perspective about this. The reason there is so much contentiousness about the affordable, part of it is some people don't like Barack Obama. Let's be clear. That's part of, that's part of the criticism of the Affordable Care Act. But for those who are opponents of the Affordable Care Act, they know that the time is running out. And why is it running out? Because when we get more and more and more people covered, it is going to mean that it's going to be very difficult to repeal the Affordable Care Act. And that's why the contentiousness is so great. So I want to just turn, if I may, to what I think will be the focus of attention in the years ahead. When Jim said he didn't think legislation was going to pass for 10 years, I guess I had nothing else to say. Is that right? But I actually think our focus as progressives who want to make sure that coverage is good and affordable, we are going to have a change in focus. And that focus is going to be on system reform. After we do what we can do to get as many people covered, we're going to have to focus on system reform. And what I mean by system reform, it's the confluence of dealing with costs and quality of care. And there's a new book that is coming out next month that I urge all of you to get and to read. I've read an advanced copy of it, and it really lays out, I think, an agenda for all of us. It's a book written by George Halverson. George is the outgoing CEO and chair of Kaiser Permanente. And George has written a book called Don't Let Healthcare Bankrupt America, Strategies for Financial Survival. And it really is, I think, a true roadmap of what we need to do as a nation in terms of system reform. And it has to do with prices, and it has to do with costs, and it has to do with quality of care. Because if we don't deal with costs, trust me, the advances we've made with Medicaid, the advances we're making with respect to the Affordable Care Act will be in jeopardy, and more businesses are going to drop out of coverage, and we're going to find coverage unaffordable. Now, one of the things that he does is he cites a comment by Uwe Reinhardt. Many of you know Uwe Reinhardt, very thoughtful analyst from Princeton, who says, "It's the prices, stupid." So I just want to give you, I want to just very quickly describe that for you. Here in the United States, the prices for care are double to triple what they are in other countries in the world. Appendectomies. In Spain, average $2,615. Germany, $3,093. France, $3,164. Canada, $5,606. Here in the United States, it's over $13,000, and some sites in excess of $28,000. Angioplasties. In the United States, it ranges from $15,000 to $57,000. Average cost, $26,000. No other country is more than $12,000. In Paris, it's under $6,000. Physician payments for delivery of a child. In Germany, physician cost $226. Canada, $460. United States, average over $2,300. And then, of course, you include all the other things like hospital care and so on, total cost $9,300. Heart surgery. In France and Germany, this is for bypass, $16,000. Switzerland, $25,500. Canada, $41,000. Here in the United States, average $67,000, and it ranges from $43,000 to $138,000. And we have different prices, not just here in the United States versus other countries. We have different prices throughout the United States. One price for Medicaid, one price for Medicare, one price, not one price, many different prices in private insurance. And then we have what's known as the charge master. The charge master is a nonsensical thing. It's sort of like, that's the retail cost, and guess who's the only one that pays charge master costs? It's the uninsured. And so we have widely varying costs. But we also have significant problems with respect to how we deliver care. We deliver care in the United States on a piece-by-piece basis. Some call it fee-for-service. We pay per service. But we don't pay for taking care of the whole person. We don't coordinate care. And that's something that has to change. Because when you pay on a piece basis, you know, it's actually better for those who receive income to actually have 2 hospital admissions rather than at the end of a hospital admission taking care of the person so that person doesn't come back to the hospital. So we're going to have a movement away from fee-for-service. We're going to have to do much more with respect to evidence-based medicine. We're going to have to do quite a bit more in looking at the concentration of different providers and what that means in terms of cost. That is going to be the battleground in the years ahead, and we have to engage that. We could not engage it as significantly as we would have liked in the Affordable Care Act because we never would have passed the Affordable Care Act had we done it. We passed the Affordable Care Act in the United States Senate with 60 votes. Guess how many votes you need to break a filibuster? You need 60 votes. We passed the Affordable Care Act in the House of Representatives with 219 votes, and we needed 218. Had we loaded all these things with changes that would have helped to bring costs down and deal with prices, some of our friends who supported us with the Affordable Care Act would no longer have been our friends. So a lot of the key agenda with respect to costs and quality really needed to be put off for another day. And that's going to be our job. After we do a really good job of getting people enrolled and making sure we deal with the coverage problem, which is so critical in the United States, we're going to have to deal with cost and quality. So let me just end by saying, why is it that we as a nation actually have so many people uninsured and our costs are so high? Why don't we do as well? And I remember in 1991 or 1992 when the Clintons were about to come to office, and we were hopeful at that point that we were going to pass significant health reform. We at Families USA were publishing a variety of books about what different countries do, not because we wanted to copy any country, but we could learn from other countries. And on this particular occasion, we had released a book called Looking North for Health about the Canadian healthcare system. And when we released the book, we did a forum on Capitol Hill, and the luncheon speaker was the Minister of Health of Canada. I introduced him, I then sat back and listened to him, and it was the most extraordinary speech I had ever heard in Washington. It was the most progressive speech I'd ever heard. And what was so remarkable about it was the Minister of Health was from the most conservative of the three political parties of Canada. So I went over to the former Premier of Saskatchewan, who was from the most progressive of the three parties in Canada. I said, this was absolutely baffling. Here is the representative of the most conservative party in Canada, and he gave the most progressive speech I've ever heard in Washington on health care. It would have made Ted Kennedy blush. And I said, what in the world could be the difference between your three political parties in Canada? And the former Premier of Saskatchewan had this impish smile on his face, and he said, I'll tell you what, the most conservative of the three political parties, they're called by this oxymoronic title, progressive conservatives. And progressive conservatives, they believe in health care from cradle to grave. Not bad. He said the middle-of-the-road party, they're called the Liberal Party in Canada, they believe in health care from basket to casket. And then his chest puffed out a bit, and he said, but we of the NDP, we believe in health care from erection to resurrection. We'll get there.
I forgot that you had said that one time. That is correct. Thank you, Ron. Next, I'd like to introduce Harold Pollack, who's a professor at the School of Social Service Administration at the University of Chicago. I've never had the pleasure of meeting you till today, but have read numerous of your articles, not only in the Journal of the AMA, but in the New York Times, Washington Post, New Republic, and Nation. And welcome, and look forward to your remarks.
Thanks so much. It's such an honor to be here. And Ron, your mother and I are so proud of you. And especially now that you have your own place, it's really great. We'll talk about that final joke when you get home. No, it really is quite an honor. The Campaign for Better Healthcare is such a key leader in the fight for a humane health policy, and I think that it is really important to be proud of what's been accomplished and also to be sympathetic critics in what needs to be done. Now, I should say I appear today in multiple guises. I'm a public health services researcher. I also am a commentator, as you mentioned, and an advocate, not as long as Ron, but an advocate for what eventually became the Affordable Care Act. And I'm also a family caregiver who relies on these precious social insurance programs every day that as many of us, I'm sure, in this audience do as well, Medicare, Medicaid, Social Security, and more. And we're so very grateful for the programs that support individuals with intellectual disabilities, in our case, We're also very well aware of the gaps in these programs. You know, one of the striking features in the recent debate over the Affordable Care Act is that many critics of universal coverage point out the shortcomings in programs such as Medicaid. And I don't know, maybe some of the young women in the audience are familiar with the term mansplaining. That is basically when a man is explaining to a woman something that women know, like aspects of women's reproductive health care, things like that. You know, when someone who has been using Medicaid for many years to help take care of someone close to them is being lectured to by someone explaining, you know, you cannot go to all the doctors that you want to go to. Sometimes people treat you disrespectfully if you are on Medicaid. How does one respond in a respectful way to that flair for the self-evident that was just reflected? And you know, much as we are proud of these programs, we are every day, we can see the ways that they can and should be better. And many of the gaps in these programs are as obvious as the smile on someone's face. I do a lot of work with severely poor people in various ways, and one of the most universal things that I observe is almost every single one of them has such horrible teeth. And one of the things, you know, Ron mentioned mentioned several issues that we have to deal with in ACA. I'm certainly very cognizant of the fact that we've not dealt with access to dental care as one of the critical issues that we need to focus on in the state and also nationally. My student Pierre Rowan and I went to Heartland Alliance. Is anyone here from Heartland today? So Heartland does such wonderful work, and we just went to the waiting room, wrote a piece in the Washington Post about that, and we just spoke to some of the patients there. And there was a man there who was homeless, and he just pulled back his lips and sort of showed me his teeth. And he has unfilled cavities, and he needs a crown, and he's been waiting on a root canal, which would cost about $1,000, which he just doesn't have. And in fact, he doesn't have the $50 to get his teeth cleaned. And so for about the past 2 years, he's been eating on one side of his mouth. And he just says, I can't chew, you know, because the teeth are very weak on the other side. And I think it's so, you know, it's so important to keep the human faces in view of the people who need us to be their advocates. And, you know, I certainly wish that we could do more to deal with such a simple issue. And there are many like that. And I think some of the affordability issues that were mentioned as well, I'm concerned about older people with health problems who will face some significant financial issues even with the Affordable Care Act. I of course, wish that we could have avoided some of the epic performance fails that occurred in the release of healthcare.gov. And as an advocate for something I'm very proud of, and then to witness that, someone asked me, how do you feel about this? And I was reminded of Lyndon Johnson's comment that he said, you know, sometimes like a mule in the rain, you just got to stand there and take it. And that's kind of what the experience was like. And as the federal government works out the kinks in the 834 forms that go to insurers and all of the technical challenges, there'll be other rainy days, and we'll have to stand there and take it sometimes then too. And I think the 3 I's that Jim mentioned are so critically important. You know, people often ask about the politics of the Affordable Care Act. This is an aspect where the politics will follow the reality in people's lives. And now let me mention a few concerns, and then I'm going to give you some causes for optimism. So well, I think one of the great challenges that Brian mentioned is the initial insurance premiums. Many people haven't paid or really don't understand what they have to do, and we have to help people understand that they're buying insurance, and that when you buy something in general, you have to pay for it, even if your share is heavily subsidized. And the marketplace's capacity to process these payments properly is something that has to be ironed out. And it's especially important that we present this in a way that the young and healthy people find this to be an attractive and helpful service for them, because the quality of the risk pool moving forward is important so that premiums will continue to be affordable for people. And I think we're in for a wild ride with many mistakes and obstacles and just hard choices implementing one of the most complex pieces of legislation ever. It's not just one of the most significant and worthy, but it's also one of the most complex. One of the ironies in this is that political moderation produces organizational complexity because we have to barnacle on everything that we do onto this existing system so that the many, many protected publics in America feel like we're not messing with what they already have and they like. And that just leads to incremental increases in complexity. And that's just what American politics is when you need to get 60 votes. One of the challenges when you need to get 60 votes is, A, we can't do some of the hard things that we need to do, and B, every single one of those senators from like 55, 56, 57, 58, 59, they all know that they are the 60th vote. And boy, that makes it, their prices tend to go up at that point when you start to negotiate. And by the way, I think those are prices that I think that when I think about Speaker Pelosi and Leader Reid and President Obama and having to actually get in there and make the sausages to make this happen, there were 50 million uninsured people. You know, that's what had to be done. And, you know, it is many of us who would like to see further changes occur can still be proud that at this moment what was possible was achieved in a very difficult environment. But certainly we are in for a wild ride, and Brian mentioned many of the challenges in his really excellent talk, I thought, before. So the good thing is that little by little the glitches and the errors are being fixed, and the reality is changing, and as the reality changes, the politics changes. You know, you can tell people that a website doesn't work, but if they go to the website and it works, that's not a very effective piece of rhetoric. I actually went to the website and it took me 25 minutes to do. I went through the whole thing. I didn't actually click there was one point where I would have had to perjure myself if I had clicked yes, you know, because I had put in, you know, different incomes to sort of see what would come out. And it started asking me questions about the old Mazda that my wife and I owned. The worst part of the website was having to set up a crazy password. I don't need one more password in my life. But so let me mention some causes for optimism, and some of which have come up. One is the public conversation has really moved, and it's moved in a way that we don't usually notice. You know, the popularity of this piece of legislation is going to move up and down. I think I have no idea what's going to happen in the 2014 election and how the Affordable Care Act will play into that. Democrats have a way of going to sleep in the off-year elections and then getting really upset and blaming our politicians because we didn't vote and therefore they are in the minority, if I speak as a Democrat for a moment. What's striking is whatever the short-term political gain or loss from ACA, some basic principles have gained broad acceptance. We have a national responsibility to provide people with access to affordable coverage. At least rhetorically, everyone has to acknowledge that. And this coverage actually has to work when people get sick. And that's a real challenge, of course, because a lot of, you know, say the Bronze Plan, if you get sick and you don't have a lot of money, you're in for some serious co-payments. But boy, that's a heck of a lot better than what's happening to most people now in the individual and small group market. And no one should lose their house because they get a serious illness. That's been established as a basic principle of the public conversation, and I don't see us ever going back from that. And that's something that the debate over ACA made real. And so that's one really important thing. So I think that, you know, we won't see a lot of legislation moving forward, but I think the ability to move backwards is very much constrained because there's a very broad consensus on the points that I just made. The second point is a little bit stranger that I would call this a cause for optimism, which is we're arguing about real stuff now. You know, we spent the last 5 years arguing about stuff that wasn't real. You know, the death panels and socialized medicine and people asking me about my sex life and all the, you know, chips being implanted in people, whatever the issues were that were basically fake, or that were stalking horses for other things about, which actually were very real disagreements in America about the scope of government and so on, but that we were debating about in the context of fake stuff. And now what we're talking about is the Bronze Plan really adequate for low-income people? Will patients with complex cancers be able to go to the places that they think are important to get their care? Will prestigious providers have too much market power as we move forward? And how does that affect the price issue that my son mentioned? How do we balance inclusive coverage with the need to maintain disciplined premiums? Now, these are really tough questions. These are hard debates. But those are the real questions about how to operate a healthcare system. Because guess what? There was no really easy way to solve all these issues in a way that makes everyone happy. Now, one challenge we have is the Obama administration now owns every source of discomfort or unwanted change in healthcare or our health insurance system. And that's a hard thing because there's just always a lot not to like in healthcare. I mean, now, at the beginning of ACA, many people talked about it as if there were these evil insurers, and then there was everybody else. And if we just get the evil insurers out of the way, we could resolve all these problems. It's a lot deeper than that. If the insurers basically poll roughly with Bernard Madoff as far as their sort of overall socialist. If they were the only problem, this thing would have been done. And the fact is, insurers have a very valuable role to play in a set of skills. And there are many other stakeholders in the system that have conflicting interests that have to be addressed and negotiated, and it has to be pushing and shoving about it. And when that happens, people are going to look to the federal government as being accountable to the results. It's hard to remember now, but before health reform was passed, there were people who had insurance plans that didn't allow them to go to the best cancer hospital in Chicago or Boston or New York. There were people that wanted treatments that their insurance company didn't cover. Maybe some of you remember those days. That was sort of supposed to be a joke. I'm sorry. There were people that had insurance with high deductibles and so on. Now there's a home address to a lot of these complaints. And it's a real test of our public policy system. Can we address that in a way that's constructive and allows us to move forward? Another challenge is the incredible importance of state governments in all of this. I think many of us, how many of you read the New York Times or the Washington Post fairly regularly on the web or whatever? How many of you really consider yourself pretty well attuned to what's happening in Springfield every day? How many of you feel good about national politics but a little less informed about your state? Many of us. I'd have to raise my hand for that. Well, that's part of the issue because the state governments are going to be doing the exchanges, and I do hope that we get a state exchange in Illinois, and state regulators are really the people who are going to make a lot of the Affordable Care Act work really well for ordinary people or not. And we're much more accustomed to seeing what's happening in Washington than we are to seeing what's happening in Springfield or in 49 other state capitals. So policymakers are operating in all of these state capitals in a very polarized environment that undermines the capacity to do mid-course corrections and to do pragmatic problem solving. We look at the federal government, we say, wow, this is really gridlocked. The same thing is true in many of the states with less public exposure and accountability. So it's not going to be easy or quick, but at least we're arguing about the real stuff. Third, things are definitely getting better. So, as I mentioned, it took me 25 minutes to go through the website and to see what really were quite affordable health insurance plans. Implementation of ACA is going well in many places. And the successes prove that the law can be implemented to achieve much of what it's intended to do. Now that of course puts some of the federal glitches into sharp relief, but those are getting fixed too, I think, although slower than of course we all would like to see. And if you look at exchanges in California, Massachusetts, Kentucky, Connecticut, Washington, the District of Columbia, completely leaving Illinois aside, and I think we've made some really important progress here in Illinois as well. Consumers are selecting their options from plans. Exchanges are correctly determining whether applicants are eligible for tax credits. People are being enrolled in Medicaid. It's really quite something. People are on track to receive affordable health care. And these are not sort of isolated successes. If you add up the places where ACA is going sort of unambiguously well. These places have a combined gross domestic product the size of Germany. So I mean, and we've just started. So this is happening, and it's working in many places. Fourth, we are beginning to see the beginnings of bipartisanship. Now, I said there's complete gridlock in Washington. I completely agree we're not going to get constructive legislation in Washington for a long time. So how can I possibly say that we're beginning to see the beginnings of bipartisanship? And I do think the fact that this thing is the centerpiece of legislation for Barack Obama is so fundamental to this thing. And some of the progress that needs to be made is going to happen the day President Obama leaves office. Because it'll just be a lot easier for everybody to do this. And that's just a reality of our political system. But we're beginning to see the beginning of bipartisanship. It's not between President Obama and Republicans in Washington, though. It's between President Obama and Republican office holders in states and localities around the United States. Because these office holders have real governing responsibilities, and both they and the president have something to bargain about to make this work. When I look at Ohio, Governor Kasich, for example. Arizona, who would have thought Jan Brewer would do what she did to get the Medicaid expansion? You remember Jan Brewer? She was the one who pointed her finger at the president when he landed on the tarmac. I never quite figured out what that was about, except I think she was selling a book at the time. There's the pressures for states and the federal government to get together are immense. There's so much money on the table. There's so many constituencies ranging from the chambers of commerce to the hospitals to states and localities that just need this to happen. And so there's a prospect for negotiation. Now, I don't actually like some of the things that the governors are asking of the federal government. For example, they would like to have co-pays for people on Medicaid in many states that I personally think are unwise. But I think it's really important that accommodation be found. And that's where some of the bipartisan legitimacy is going to come from. And that's also where a lot of the people who need help are going to find that help coming. You know, if a governor wants to put people in Medicaid into exchanges as a way of having a dignified path for him or her to deal with the president, boy, that's something we should take very seriously, because there's hundreds of thousands of people in these states that need a dignified path for the relevant politicians to be able to move forward. And it's not going to be easy on either side, because it's not easy for Democrats, because Democrats have to recognize, this is not 2008 or 2009. And it's not easy for Republicans, because they have to realize it's not 2010 or 2011. And that's just the way American politics has to move forward. And it's going to be this state-federal relationship where a lot of the really interesting and important stuff is going to happen, and where we have to pay close attention so that we can understand what's really important here, what are core principles, and what are areas where you need to give some space for the states to find their own path to working with this new piece of legislation. Fifth, this is going on. I just saw Fidel Castro give a speech at the Mandela thing. He's kind of my role model for today, so I'm going to go on for another couple hours. The gears of the American health system are actually beginning to turn better. One of the quiet stories is healthcare is getting better in America. And over the past couple of years, we're really starting to see this. And in some ways, ACA exemplifies and has accelerated the momentum for what has to happen. On both the quality and the cost side, you can really see some tangible signs of improvement, although we don't know how sustained some of those things will be and exactly who deserves credit for that. But I think it's fair to say that ACA has been helpful in that. First of all, Medicare and Medicaid cost increases have really slowed. And some of that moderation reflects the recession. But as time goes on, the progress obviously is going deeper. And Doug Elmendorf, who's the director of the Congressional Budget Office, reported some of the good news about 2 months ago in a report. And growth in spending for the fee-for-service portion of Medicare, which in many ways is the atomic bomb aimed at the federal budget. I mean, really, if you say, when people sometimes talk about entitlements as the real problem in the federal budget, and then they say Medicare, Medicaid, Social Security. Well, within that, Social Security's unfunded liability is about 1% of GDP moving forward. And then, so you say, okay, it's Medicare and Medicaid. But then you look more closely and you say, well, Medicaid actually has had far lower growth per recipient than any place else in the healthcare system. And then you get to Medicare and you say, wow, actually, I'm really panicking now. And if you look at what's happening in fee-for-service Medicare, what you find is that the past few years, the growth in spending has really slowed. Not just because of the recession, but because of other factors. And relative to the March 2010 projections when health reform was passed, the latest Congressional Budget Office projections for what's going to happen in 2020 suggest that Medicare spending will be about $137 billion below where they expected it to be in that year. That's a 15% decline. And if you look at Medicaid, they have a 16% decline relative to what they expected. They also have revised downward their 2020 projections of private health insurance premiums by about 9%. This is hugely important, and it basically offsets a huge amount, maybe all of the actual additional costs of covering people through Medicaid and the exchanges in ACA. Now, do these reductions solve our nation's budget or health care expenditure problems? Not entirely, but boy, they help. And it is really striking how this could be the single most important change in American politics and in the American economy if it holds up, which is if we can control the growth in Medicare and Medicaid back to, if we can get rid of the excess and just have the problem be, well, our population is aging, we're in a different world. And if we can't do that, as Jim and Ron and others point out, then we're really in trouble because we'll destroy the federal government if we can't control health care costs. But things are really, in the past several years, looking a lot better. And it's not just on the cost side. There's a whole series of trends. David Cutler, a health economist at Harvard, has looked at a range of things from hospital readmission rates to in-hospital infection, and you see things are getting better. And it's really something that we can take pride in. And now no one can say how much of this is due to the ACA, but the alphabet soup of stuff, or what I sometimes call the junk DNA in the Affordable Care Act, the sort of pages and pages and pages that nobody reads, but that specifies what accountable care organizations do and Medicaid, health care homes, and things like that. A whole series of efforts to move away from the pathologies of fee-for-service medicine are being pushed ahead by ACA and have really signaled to the industry, to purchasers, to customers, we have to change the way we provide health care in America. And that message is really getting through. Now, one of the sad things is most of that stuff is entirely bipartisan. I mean, if you talk to Medicare officials in the Bush administration, they would look at 80% of what's in the ACA and say, these are exactly what we need to be pushing on, these kinds of innovations. But because it's in this bill, it's become very polarized. Who would have thought comparative effectiveness research, which insurers desperately, desperately need, would become death panels in the public discussion? Insurers have to have a way to say no. Suppose that somebody comes along and says, I want to do a proton beam treatment for people with prostate cancer. You ever see a proton beam machine? They're $200 million each. Their major evidence-based validation in the research literature is for pediatric cancers. Where are they building these right now? Scottsdale, Arizona, I think, has 4. Of course, they're being used for prostate cancer among older people. Insurers desperately, desperately need someone to say, hey, this is not evidence-based. But because it's in the ACA, it's so hard to do. Little by little, these things are moving ahead. And I would say one other thing that's really moving ahead, which is finding ways to improve the care of really expensive and complicated patients. There's basically 2 things we have to do to control costs in American health care. One is we have to deal with the price issue that Ron mentioned. The second is we have to deal with, in a more humane and economical way, to provide better care for people with really expensive conditions in a different fashion. I'll give you an example. Illinois Medicaid right now. The bottom 72% of current recipients account for less than 10%, or about 10% of the program's total spending. The bottom 72%. So people sometimes say, we need to give people more skin in the game to cut costs in Medicaid. Is it relevant what we do for the typical Medicaid recipient because they don't cost us anything? The top 3.2% of recipients, that's half of the total program's cost. But you can't ask them to put skin in the game because there's just, their cost is their care is so expensive, and they have so many complicated problems that we can't expect them or their families to deal with the responsibilities of care management. But we have to find ways to provide better care, and not just medical care, but also deal with the psychosocial issues that people have. There are homeless people with very serious conditions who end up in ERs and nursing homes who could be housed in a much more economical and humane place. And we're starting to see efforts to do that. The AIDS Foundation and Heartland are two examples of organizations that are doing that. And so I think that's really important. Now, I should say there are no miracles here. There are going to be glitches and setbacks in all this because it's the real work. It's the real political work. It's the real health services work that has to be done. Let me end with where I started. So as I mentioned, my personal role began in health reform about late 2007, later than many people here. But I was actually a campaign volunteer. And I was asked to test out the Obama campaign had a new computerized phone system. How many of you were terrorized by computer phone calls from the Obama campaign at some point in your life? That's my fault. I was one of the people. I was brought out to the West Loop to a boiler room to test out this new computer phone system. And I was given a long call sheet to talk to my people being rural African American people in South Carolina. And so I meshed immediately with all the people I was calling. So I called a few hundred people and talked to them about some senator they were starting to hear about named Barack Obama. And those were kind of innocent days before everybody was inundated with these phone calls. So I could actually have some pretty intimate conversations with people. And one of the really striking things was many, many people on this list were middle-aged or older, very low-income people often, and many with some really worrying health problems. And I remember one man starting to tell me in detail about his own and his wife's various infirmities. They had diabetes, and they had some very serious medical bills. And he couldn't have been more supportive of the political campaign. But he said to me, he just asked me these simple questions that really took me aback. And he said, if Senator Obama is elected, will he help me? And he didn't mean by that, like, could you send me a Will I Am video, please, and a T-shirt? He didn't care about that. He meant, I have some bills on my kitchen table right now that I can't pay. And will you help me? And the directness of that kind of hit me like a punch in the stomach. Because, of course, I gave him the usual spiel, if Senator Obama's elected, he'll work every day, to yada, yada, yada. And I knew what a big slog it was going to be, and that people like Ron were going to be making this happen, and how difficult it had been, and how Hillary Clinton was going to try to do the same thing, and she was just as committed as President Obama was, and how she had failed once before. And I wonder, it was kind of a heady time, but I really wondered, I thought there's a good chance we're going to get elected, and are we going to let these people down? And I was actually in the back of the room when health reform was signed, and I remember seeing the president. I felt, we had kept our promise to those people, and I talked to many people who had health problems on the campaign trail. Retail politics is a great way to meet ordinary people and to find out things you won't find out in an academic journal. And I met one person who was going medically bankrupt. He was on the liver transplant list, getting superb care. He was on SSDI, but he was in the waiting period for Medicare. And he was hemorrhaging money. His family was actually having a garage sale. They were selling little trinkets on the lawn. And they probably raised $2,000 or $3,000 that day, which is probably one day in the hospital. When I read Washington Post accounts of the thousands of rural Kentuckians who are getting health care for the first time, I just feel that promise was kept. But when I think of the morning of the Supreme Court decision when Justice Roberts said, Medicaid expansion is optional for states, I thought, I have just failed to keep my promise to that man in South Carolina, at least for the moment. So I still am not sure we kept that promise, but it's really important. They're, especially, I think that story bank that Jim mentioned is really important because there's going to be a mix of winners and losers from this, and there's going to be more winners than losers. But the people who are losing something are going to tend to be relatively healthy and affluent people who are in the individual and small group market, who are not eligible for subsidies, and who are going to be angry about it. And they actually have some reason to be angry about it, but they're going to get an awful lot of attention. And many of the people who are going to gain from the Affordable Care Act are going to be less organized people in less advantaged circumstances. They won't be losing something they already had, they'll be getting something they never had. And people pay less attention to that, particularly in American politics, the way it is right now. And so it's, with all the complexity and all the political negotiation, we can't lose those stories. And we can't lose sight of the moral dimension of health reform, that we have to take care of each other and make sure all these people are helped. So with that, I think I'll stop, and thank you very much.
I think both of the Pollacks answered all the questions that were sent to them beforehand, and I want to thank you both for very insightful, visionary, and very grounded remarks. I think let's give them another round of applause.